Welcome everybody to the 3-minute thesis final for the Faculty of Population Health Sciences. So welcome everybody. I hope some of you may have seen this type of competition before. For those of you who haven't, it's good fun. Hopefully you'll learn a bit. I thought I'd give it just 2 or 3 slide introduction to the background of it, for those of you who are not familiar with what the 3MT, where it came from and what it is and what it's for, etc., before we kick off. Just before I do that, we're filming all of the talks, so all the speakers. We're filming them. If anyone doesn't want their recording kept, tell us at the end and we'll delete that part of the presentations. Okay. I mean, hopefully we want to put some of these presentations online as an advert, for the faculty and the work that we're doing. So apparently this is true. I'm not sure if it really is. It was the competition started in Australia. Started in a professor having a shower, apparently. They had a drought, and they were timing the showers that they had. And they had the bright idea, the dean of the college decided this would actually be a good idea to have a 3-minute competition for presenting PhD research. And that's apparently where it was born quite a few years ago in Australia. It's now very much an international competition. UCL sort of embraced it 3 or 4 years ago, and it's been gradually growing in subsequent years. And this is obviously the faculty final. You've all hopefully had institute competitions, and the winners from the institutes have come here to the faculty final. We've got 9 speakers today. The first speaker is a warm-up act, effectively, because she's from not from our faculty, she's from the arts and history faculty. But the other 8, the reason for that is because their faculty wasn't running a final like this, so we agreed that she could have some practice by coming to this competition today. But she's not really effectively taking part in our competition. So the main 8 talks are from various departments within the faculty, and I'll list those as they come up. They all have one slide each. They all have 3 minutes. It's all a fairly standard structure. So we all know what, if those of us done PhDs, the dreaded question, you're talking to your friends and family, parties, whatever, what's your PhD all about? So this is kind of what this is about to some extent, is explaining quickly, succinctly, in an interesting way, and what is your PhD about, and get people excited about what you're doing. So what is it good for? It's great for the students to advertise their science to non-specialists, ultimately. Advertise yourself is a good forum for students to project themselves and the work that they're doing. And obviously the gaining key skills in science communication, outreach, public understanding of science, etc. So it ticks all sorts of boxes. And I see in the audience today there's some non-academics here, so we really encourage people from other staff levels at these institutes and faculty to come along and listen to the research that's going on, because it's often the only opportunity you might have to actually hear about the science that you're supporting. So the rule, I won't go through all the rules, but most of you probably know this. So it's a single slide only, no transitions, no movement, etc. 3 minutes maximum. If you go over the 3 minutes, I'll have an iPad timer at the front. If you go over 3 minutes, you're, in theory, disqualified. Depends how I'm feeling today. You're only allowed to speak, no singing, poems, rap, all that stuff. No costumes. There's no costumes here today, which is good. And then we have a panel of 4 judges here who've kindly agreed to adjudicate today, and they'll be scoring you as you go along. And when we finish, around about 3:30, there'll be tea and coffee out there, and during that break, the judges will meet and decide on the winner. So unfortunately, there's only one winner can go through to the UCL final today from our faculty. That's the rule this year. But all the contestants will get a certificate of participation anyway, but there will only be one prize for that. There'll be 3 prizes at the same time for the posters, which has been run earlier today. So I think we're just about ready to go. So we'll do them with the first speaker is Alexandra Booth, who, as I said, is from the Faculty of Arts and Humanities, and she's going to be talking about a very topical issue anyway, which I'm sure will interest everybody. And as I said, we won't score it. We'll give you some feedback, hopefully, at the end, so you'll be able to hopefully do even better in the main UCL final. So I'll start you off with that, and here's the slide, and I'll get the timer ready. So when I start the timer, you can kick off.
Okay, Brexit leaflet 2016. But today I want to go back to 2014 when Nigel Farage suggested to you that you should be more afraid to live next to Romanians than to Germans. So let's suppose that you never met a Romanian in your life until one day when you go back home and you see this massive pile of suitcases and furniture next doors. Yes, someone new is moving in and they are Romanian. So theory says that you have two possibilities here. Conflict theory. It's 6 a.m. in the morning, you go to work, and you find out that your neighbor comes out of his house at the same time, and he's dressed up in the same work uniform. All this whilst your mate John was refused work at your workplace yesterday. So you're quite inclined to think, oh well, those Romanians taking our jobs, right? And this is exactly what conflict theory suggests, that competition over scarce resources creates more out-group hostility, in this case towards migrants of different ethnicities and backgrounds. Contact theory suggests the situation when you are, let's say, having a barbecue the next weekend and you kind of see that your Romanian neighbor is also having a barbecue and you start chatting and then later you go on for a pint and you realize this guy is quite alright, right? And then you become best buddies in no time. And this is when contact theory suggests that contact with migrants breaks down stereotypes that are often built by the media and politicians and help create better community cohesion and relationships between different groups in society. But those two scenarios really depend on the location you live in. So this is why for my PhD, I do fieldwork in two very different locations in the UK, in Clacton, where 98% of people describe themselves as white British, where it's very rare that you'll have a Romanian neighbor, and in West Ham, where 1 in 5 people describe themselves as white British. So you'll have plenty of Romanian neighbors on that logic. My PhD looks at how nationality, ethnicity, and location shapes attitudes towards migrants on the ground, and hopefully my research will lead to more informed evidence-based policy that is really needed in the context of Brexit, and lead to a better understanding of how we can improve community cohesion and relationships between different groups, both from the EU, outside the EU, and British people living in the UK. A more evidence-based policy is really needed in the current hostile environment, as you all know, and I hope my PhD will contribute to that. Thank you.
So HIV is a virus which damages the immune system of infected individuals, meaning that they cannot fight infections properly. Although there's no cure, there is effective treatment which can reduce the amount of virus in the blood to very low levels, which allows the immune system to recover. And in addition, researchers recently confirmed that once a person has achieved this so-called viral suppression, they're unable to pass the disease on to anybody else. So treatment has benefits both to the individual and also to society as a whole. The Cascade of Care is a model which describes the steps that an infected individual needs to pass through to achieve this goal of viral suppression. So it can include things like being diagnosed in the first place, being linked to care, and starting on treatment. And it's widely used as a tool to monitor the progress and the performance of HIV healthcare systems over time and to identify gaps in care which need improving. In 2014, the ambitious 90-90-90 treatment targets were announced, with the aim that by 2020, 90% of infected individuals would know their status, 90% of those who'd been diagnosed would be on treatment, and 90% of those on treatment would be virally suppressed. My PhD is looking at this cascade of care specifically for infants in South Africa, and South Africa is the country with the largest number of HIV-infected people globally at around 7 million. And the prevalence is particularly high in an area called KwaZulu-Natal, which is a deprived rural area in the northeast of the country, where more than 1 in 3 people are infected. And this is the area that I'll be focusing on. So the work I've done so far is looking at the first step of the cascade, so that's the testing of babies born to HIV-positive mothers. And South Africa recently became the first high HIV burden country to recommend routine testing of all infants, all HIV-exposed infants, as soon as they're born. But because this test might not pick up babies who became infected either late in pregnancy or during labour, a second test when they're 10 weeks old is recommended as well. But there are practical difficulties with this. For example, how to explain to a parent whose baby tested negative at birth that there's still a risk they could be infected. And it's especially difficult in the context of a rural community where people often travel long distances from their homes for medical care. In my research, I've observed that after being tested at birth, only 23% of HIV-exposed babies received their second follow-up test. This could result in a huge number of missed infections and, in turn, high mortality rates, since without treatment, around half of babies will die before their second birthday. Future work will aim to identify the characteristics of these babies who are dropping out of care and the reasons for this in order to improve infant testing strategies.
Critically ill children in some parts of Africa don't have very good chances. If they have a serious illness such as severe malaria, pneumonia or sepsis, then firstly they may have a very long way to go to their local hospital. And secondly, once they arrive, the equipment and treatments they receive there are limited, especially in comparison to what you would get in a paediatric intensive care unit in the UK. They will get antibiotics, antimalarials and blood transfusions if appropriate and put on a drip, but there are limited supportive therapies to treat the immediate critical state that they are in. The Fluid Expansion as Supportive Therapy, or FEAST trial, aimed to address this by researching whether an internationally accepted emergency treatment for children in shock used in the US and Europe could be given in hospitals in Africa to prevent children dying. The treatment involved giving fluids rapidly through an IV line to restore circulation and help improve perfusion, that's sort of getting your blood to the right places in your body, in order to correct the shock. The trial unexpectedly showed that this type of treatment was not suitable for children in these settings and led to many questions being asked about the trial, the treatment, and why this result occurred. My PhD aimed to address and answer some of these questions. The first was whether we could better prioritise children in general and what were the signs we should look out for. For example, heart rate, pulse, temperature, things like that. I developed a risk score, like a checklist of signs, so children could be assessed quickly by the nurses and so triaged appropriately, so those with lots of signs and a high score could be prioritised for treatment. I have also applied the score to other data sets and showed it worked successfully in similar settings. It could also be something developed into an app for a phone or a paper checklist to be used for triage in hospitals in Africa. The second question was whether I could identify a sign, something like heart rate, that worsened because of the fluid treatment and could help us explain why the treatment was harmful. That sign could also be something measured by researchers trying to replicate this trial in different settings. I also looked to see if there was anything we could identify that we were measuring that showed the fluid treatment was worse or better in certain groups of children, and whether that could help with explaining the mechanisms of the treatment. Finally, I looked at when the children were dying and were at highest risk of dying, and if that was different between those that had received the treatment and those that didn't. I found that those who had the fluid treatment were at higher risk for longer, and that mortality risk took longer to return to normal. I'm hopeful my findings will inform future research in critically ill children in these settings.
I'm here to talk about the most devastating health crisis of our time. I'm not talking about cancer, and I'm not talking about dementia. In fact, diabetes affects more people than these two illnesses combined. Type 2 diabetes is an illness that affects the hormone insulin, which causes the level of sugar in the blood to become high. This can lead to catastrophic complications like amputations and blindness. But there is a way to reduce the risk of complications, educating people about how to self-manage their illness. On average, patients with type 2 diabetes only spend 3 hours a year with their doctor or nurse. For the other 8,000 hours a year, they're left alone to manage their illness. Face-to-face courses are available, but uptake is very low, and it's an NHS priority to increase the uptake of self-management education. We already go online for health information all the time, so why not provide self-management education online too?
I took this idea and I turned it into an online programme called Help Diabetes Starting Out, which is commissioned in 5 boroughs across the UK. These are the steps that I took. The aim of my PhD was to develop, optimise and evaluate the programme, and I used principles from healthcare research and also computer science. I started by developing the programme components using theories of behaviour change and long-term condition management. Then I piloted the programme and subsequently evaluated it whilst it was being implemented in the NHS. I also looked at who was visiting the website to understand if older people, people with less education, and people from ethnic minority groups were using the programme too. I also tested strategies to encourage people to continue using the programme, using things like telephone reminders and also offers of incentives. In the time it's taken me to give this presentation, one more person has been diagnosed with type 2 diabetes. Treatment's come a long way in the last 20 years, but there's still more that we can do. I've shown through my PhD that online education is feasible to deliver in the NHS. It's also acceptable to patients, and it can help improve self-confidence and self-management and reduce emotional distress. Further research needs to be done to understand how online education compares to face-to-face education, and it's important to do this work so that we can give people more options for learning about their illness and to improve their health. Thank you.
As I tell you about my thesis, I'm also going to tell you a story about Betty. Betty is a 72-year-old Englishwoman who has fairly average health. Many of you may have a Betty in your life. It could be a mother, a grandmother, or even a next-door neighbor. As Betty gets older, she's becoming very concerned about her balance. She's really worried about the consequences if she falls. She knows that 1/3 of adults over the age of 65 fall every single year, and this could lead to hospitalization, losing her independence, or being afraid to go out in public. Betty is one of 5,000 study members in the National Survey of Health and Development. These study members were all born in the same week of each other in 1946 and have been followed throughout their entire lives. Their standing balance was assessed in their 50s and twice in their 60s using the standing balance test, where they had to stay in this position for up to 30 seconds. My PhD looks at 3 different stages of these individuals' lives. So first we looked at early life, and we found that those who had higher childhood cognition were more likely to have better balance ability in later life. We also found that those who reached milestones at an average age, so they were able to sit and walk at that average age, were more likely to have better balance than early and late developers. How many of you have heard a young mother boasting about how her baby is a faster developer than others? Well, you can let her know that early development isn't necessarily always an advantage. Next, we looked at adult cognition. In order to successfully balance, our brain needs to combine sensory information. This is things we see, things we sense, and information from our muscles. And what we found is that different types of cognition, and that included attention, memory, processing speed, as well as just general knowledge, were all associated with better balance later in life. And finally, we looked at later life. And as expected, we found that those study members who had better balance were less likely to fall. But what was really interesting is that most fall research looks at those over the age of 65. And we found that patterns of balance in their 50s and early 60s could also predict fall risk. So rather than waiting for older adults like Betty to fall, balance can help us identify who's at risk and help us identify when we can intervene. And by understanding how these different factors across life contribute to balance, we can identify earlier interventions for our aging population. As academics, we're all searching for a little work-life balance, but maybe, like Betty, we start working on our standing balance too.
Parenthood, what an amazing change in a person's life. A bundle of joy is welcomed into your home. But not before long, the worrying starts. Are they eating enough? Are they drinking enough? Is their weight changing in a normal manner? From when they're babies to toddlers to teenagers, all the way to adulthood. In fact, we all take a close look at our body size and shape and set a name for a healthy lifestyle. Currently in Britain, 3 out of 10 people are obese, based on a body mass index value greater than 30. which puts Britain at the 6th heaviest position out of a group of 35 wealthy nations. So, what is the body mass index? The BMI is merely a mathematical combination between height and weight. And BMI charts like the one shown on the left are used to identify extreme cases in the population. But is creating an index the best we can do with weight and height? I don't think so. My proposal is to analyze the variables separately and concentrate on the relationship and the patterns that emerge between them. We do this via bivariate centiles, and these are the circular shapes that you see on the right-hand side. And these are what my PhD is all about. Bivariate centiles enable us to identify extreme cases in the population based on the joint relationship between numerical variables such as height and weight. In fact, all the points that are outside the blue line on the graph on the right are the joint outliers. Joint, that's a key word in my studies, as it's all about the joint or bivariate relationships that are used to explicitly analyze variables instead of creating an index like the BMI. Bivariate centiles have also allowed us to identify hidden extremes. These are cases in the population that would have been missed if we had looked at each of the variables alone. And these are the red points on the slide. Think of the transitional applications of this. Well-being and anxiety, GCSE and A-level marks, gas and electricity consumption. How do such variables change together? Their relationship should be the focus when we're trying to identify extreme cases in the population, and more interestingly, hidden extremes. We can extend this to account for socioeconomic and environmental factors, as well as to more than two variables. My PhD will establish a statistical tool that will enable researchers to identify joint extremes in the population that will then inform policymakers as well as their own life choices. So next time you think of any two related numerical variables, think of bivariate centiles. Thank you.
By the time I finish talking to you today, each of you will have lost around 18 neurons in your brains. Now, losing neurons, it's not a big deal, actually. It happens to all of us as we age. But we can't regenerate them. We can't get them back, right? Or at least that's what we used to think. Because now we know that actually there are two places in our brains where we can make more neurons. One is in the olfactory bulb, has to do with our sense of smell. And the other is in this amazing part of your brain called the hippocampus that stores all of your memories and everything that you learn. Now, for my thesis, I asked just one question, and that question was, can people who have a rare genetic condition called Bardet-Biedl syndrome, where they have real difficulties with their learning and their memory, and they have really small hippocampi, can they improve their memory and the size of their hippocampus through one simple lifestyle intervention? So you might say, well, what kind of intervention can you do to increase the size of your hippocampus and your memory? And paradoxically, we can take a clue from Alzheimer's disease. Because we know that in Alzheimer's disease, as people's memories shrivel up, so do their hippocampi. And we know that there is one thing that they can do to slow that decline, and that thing is physical exercise. In fact, physical exercise is so powerful that we know that even healthy people who exercise do better on average in cognitive tests than healthy people who don't exercise. So exercise makes you smart. Okay. And that brings us right back to my study. I invited a group of children with this rare genetic condition called Bardet-Biedl syndrome into Great Ormond Street Hospital. And we did an assessment when we looked at their memory, we tested their fitness, and we also did an MRI scan of the brain and looked at all the different structures, but in particular, the hippocampus. And then we divided them up into two groups, and some of them went away and worked really, really, really hard with a personal trainer to get super fit, and the others had their normal management. And after 6 months, we brought them all back again, and we did the assessment again to see if anything had changed. And the amazing thing was that when they came back, we found that those people who were fitter had better blood flow to their brains, they had trends towards better memory scores, and they had bigger hippocampi. So my take-home message from today is twofold. One, you can improve the size of your hippocampus and your memory through exercise. And two, our genes are not our only destiny. So you may just have lost a couple of neurons in the last 3 minutes, but if you hit the gym, you may just get a few back.
You've just changed your newborn baby's nappy for the first time. His femur has broken. Your 1-year-old daughter has just pulled herself up against the table to cruise around the furniture. Her humerus has broken. Your 15-year-old doesn't want to go to school today. He's afraid that in the bustle of the school halls, he'll break again, despite his motorized wheelchair. What all of these children have in common is that they have osteogenesis imperfecta, also known as brittle bone disease. This is a congenital disorder, normally caused by a spontaneous mutation in the type 1 collagen genes, and it can give rise to mild or severe forms. Individuals affected by a severe form of osteogenesis imperfecta have very short stature, frequent fractures, and progressive bony deformities. And this actually can be diagnosed on ultrasound when women will go for their 20-week scan, and we will already be able to see that their baby's bones are broken inside the womb. Current treatments are things that are supportive, such as physiotherapy, controversial medical treatment with bisphosphonates, or orthopedic procedures such as having metal rods put down the inside of the bones to try to make them be straight. There is no cure, or is there? Stem cells are cells that can become anything we want them to be. Well, not quite anything that we want them to be, but the type in question, mesenchymal stem cells, on the background of this slide, can differentiate and become fat, cartilage, or bone. And they've actually been used in quite a lot of clinical trials, and the evidence is that they're safe. They avoid an immune response, they avoid rejection, and they don't form cancers. So could they be used in osteogenesis imperfecta? Well, yes. There's a growing body of preclinical work in a mouse model of osteogenesis imperfecta that says that when these cells are injected either prenatally or shortly after birth, they can migrate to the bone and graft, and that they can improve the bone properties. So they can improve growth and they can decrease fracture rates. And they've also been given to 3 fetuses in utero who've all done much better after they were born than we would have expected that they would do. So this is where I come in. Number 1, I'm working on a clinical trial where we aim to give these mesenchymal stem cells as a therapy to 15 fetuses in utero with brittle bone disease, and also to 15 children in the first year after birth, where we can see the answer to my first question: does this work as a treatment? And secondly, my laboratory work aims to assess how this works. But I've just told you, haven't I? The cells migrate to the bone, they engraft, and they make bone cells, don't they? What I didn't say is that nowhere have we ever seen a level of engraftment more than about 2%. So that isn't the way that they're working. And we think that they're actually communicating with the pre-existing bone cells and giving them a message how to improve. And that's what I aim to find out. So let's just go back to that first case. Your baby still has OI. It's been given the treatment, though, in utero. There is no fracture. There is a punami, but I think that's something we can all deal with.
If you can imagine an orchestra, the easiest way to describe it would be the musicians, each one specialized in an instrument, but we also have the conductor. The conductor is in charge of coordinating everyone's actions to produce a beautiful melody. Our brain works in a similar manner. We could roughly describe our brain as composed by excitatory neurons which process information coming from our surroundings, but not all of these neurons can act at the same time. And the inhibitory neurons in our brain are the ones that are in charge of coordinating their actions to produce appropriate responses. In Dravet syndrome, a mutation in the SCN1A gene, which encodes the ion channel NAV1.1, renders this protein non-functional. That means that the inhibitory neurons are losing their baton and their ability to coordinate brain function. This means that the excitatory neurons have an increasing stream of activity that we finally see as seizures. And unfortunately, we don't have a meaningful way of providing a treatment for these children. My PhD project aims to develop a gene therapy approach to deliver the correct copy of this gene into the brain of these children. We would like to use some viruses called adeno-associated viruses to deliver this copy into the brain. The problem is this gene is too big to fit into one of these viruses. That is why we have developed a way in which we can split the gene into 2 viruses. we aim for these two genes to join together into the same cell and then deliver a functional protein. We have early evidence that when these two genes are expressed into the same cells, as you can see there, by electrophysiology we can detect a depolarization of the membrane. That means that the cells that have both viruses can actually act as if they were neurons, and that we are actually delivering a functional ion channel to them. With this encouraging evidence, what we aim to do next is to test these viruses in a mouse model of the disease. The idea would be to at least ameliorate the symptoms and maybe in the future provide a better treatment for these children.
Have you ever wondered how a medication that you take ends up at the right place in your body? To a small drug molecule entering the body, it's one big maze, and taking one wrong turn can result in a serious side effect. It is the job of pharmaceutical chemists such as myself that help drugs get to their intended target. I work on a disease called pulmonary arterial hypertension. It's an inflammatory disease which affects the vessel taking the blood from your heart to your lung, and the vessel becomes narrow and blocked by overgrowth of the smooth muscle cells. This results in poor gas exchange, which makes the tissue become slightly acidic. Although there is treatment for pulmonary arterial hypertension, the treatments work on all the vessels in the body, not just those in the lung, which results in lots of side effects which cause patients to terminate their treatment. The aim of my project is to design a structure which carries the drug directly to the lung. So I've attached drug molecules, which are depicted by the stars, along long biocompatible polymers. Binding them in this way makes them inactive, so this structure can circulate the body without having any effect. However, once it reaches the acidic environment, the bonds holding the drug to the polymer break, and this releases the active drug into the diseased lung. I've made one structure like this so far, and we've measured the release of the drug over time at different acidities. Ideally, we'd like to see a straight line for the pH 7.4, which is physiological acidity, and then an increased rate when you reduce the pH and increase the acidity. Although we see this trend, it's not quite sensitive enough for pulmonary hypertension treatment just yet, but we do have a couple of other structures to be tested. It is thought that this treatment, this approach, will not only help the treatment of pulmonary hypertension, but also other inflammatory diseases such as rheumatoid arthritis and inflammatory bowel disease. By targeting the drug to the lung, we are increasing the efficacy and reducing the adverse events which limit the quality of life of the patient.